All right. Hi, everyone. I hope you can hear me. I had my headphones just shut off on me, and whenever that happens, it's a terrible situation on Zoom. Welcome to this edition of Progressive University, which is a offshoot of the a spinoff, if you will, of the Progressive Summit. And tonight's edition is going to be on healthcare, which is an issue that we get to work on a lot here in Battleborn Progress, and that we're very proud to work on, specifically with the guest of honor here tonight, Margarida George. We get to work with her a lot. She is with HCAN Healthcare for America Now. Margarita, you want to turn on your camera and come on and say hi to everyone?
Hi, everyone. I'm trying to turn on my video, but it says I am not allowed to do it because the host has stopped it.
Oh, hang on. Let's see. Mike, can you help? Because I don't think I can do it. Let's see. Try now, MJ.
There
There
you
we
are.
go.
All right.
Mike for the win. Well, welcome, MJ. We call you MJ. Your full name is Margarita George. Welcome, and tell us a little bit about yourself before we go into HCAN. But tell us who you are, MJ, because we all love you here at BBP.
Um, Great. I always feel at this moment like I should make up something more exciting, but in the interest of time, I'll just go with truth as a tactic. I'm Margarita George, MJ. I am just an organizer. I've been an organizer for about 27 years. I started knocking on doors in Mississippi when I was a baby organizer, as Ense Ufa says, from the Georgia Project, organizing poultry plants with labor. And I thought I was going to do that for a summer because I'm a good immigrant kid and I was supposed to go to college and do, bigger, better things. But I then ended up doing it for 15 years. And so um, I did a lot of door knocking. And then early in 2007, I was invited to come up to Washington, D.C. and lead a big healthcare campaign for the Service Employees Union, who at that time had the biggest healthcare campaign in the country. And that was because we sort of saw that there was going to be a chance for healthcare reform, and it brought together just groups from around the country to, sort of a historic time. And then here in Washington, SEIU and a bunch of other stakeholders created Healthcare for America Now was the biggest campaign of its kind. We passed the Affordable Care Act, a huge healthcare reform that restructured a fifth of the economy. And I have been here in DC ever since, really trying to get away from healthcare and work on some other issues. But as a lot of you guys probably have found, all roads really do lead back to healthcare. It's a really personal issue that people care about. And so I have found pretty much my entire career that even when I've tried to work on other things, whether it's criminal justice reform or taxes or paid leave or, pick it always brings me back to healthcare.
That's awesome. And you are, you can tell that you are an organizer to this day. So your baby organizer is with you all along. Uh, so let's continue on HCAN. And for those that just joined us, who was just speaking as our professor for today, Professor Margarita George from HCAN. And I'm Maria Teresa, the Deputy Director at BBP. So welcome. Thanks for joining us. And if you have any questions or you just want to say hi, please use the chat function. We're using the webinar option. So that's how we'll be able to get your messages through the chat function. So use that throughout tonight to ask any questions, clarifying, or just say hi, how you doing? So tell us a little bit about You gave us the history about HCAN. What is it specifically that HCAN is focused on now in the present moment?
Well, we are an unusual group for a healthcare group because we are a coalition of organizations that came together to fight on healthcare. But over the last 10 years, we have fought on a lot of things because healthcare is often tied up with a lot of things. And we're going to see that when we talk tonight, because we don't have very many standalone pieces of legislation. What we have are these big monster bills where a whole bunch of stuff gets mobbed up together. And a lot of that stuff is going to be healthcare stuff. Over the last 4 years, we've been really focused on protecting Medicaid, Medicare, and the Affordable Care Act. And that's because under the Trump administration, those programs have been pretty aggressively under attack. And we've seen them under attack both in Congress and through executive action, and definitely in the courts. We do a lot of work on reproductive health care. We think that's a really important component of health care. We've done a lot of work over the last 4 years on taxes, to be honest. A lot of the damage that's done to healthcare is done through the tax code. And many of the things that we'd like to see in the future of healthcare, right? Not-for-profit healthcare for everybody in America, that is going to cost a lot of money. And, thankfully, we are in a very rich country that actually has a lot of money. But to get there, we would have to make the rich and corporations pay their fair share. And what we saw under Trump was the reverse. We saw the rich and corporations get trillions in tax cuts. And of course, over the last year, what we've been working on the most is the same thing that probably all of y'all on this call have been working on, which is COVID. And how do we mitigate the impact of the public health crisis and the economic crisis, right? We have seen conditions in this pandemic that really mirror, historic times, the Great Depression times. You guys are in Nevada, so it's ground zero really for COVID.
And thank you for the work that y'all continue to do to help groups like BBP be part of those efforts. We're very happy to be part of that coalition you mentioned. So now that we know where we are in the present moment, let's actually take a little step back and talk about the Affordable Care Act, which you mentioned was a big part of what HCAN has worked on. And I think it's still a work in progress because we're fighting the attacks that it has gone through in the past few years. So the ACA, the Affordable Care Act, was the first step in improving access to healthcare, just simply giving access to millions to healthcare in the US. Then Trump became president. So walk us through, for those that didn't keep track of the attacks that the ACA went through, tell us exactly just how the Trump administration gutted it and where it's at now.
Yep. So I'll say it's helpful to think, if you don't know that much about the Affordable Care Act, it's helpful to think about it in two ways. So the law did two big things that were really historical things. One is it covered more people than had ever been covered in the United States. Not everybody. At the time that we passed the law, there were 47 million uninsured people. It's a pretty large number of people. After passage of the law, that number sank to historical lows, but we still had only covered 27 million people, right? So we still had another 20 million people to go. So, and a lot of that extension of coverage was done through the Affordable Care Act marketplaces, but actually a lot of people don't know that most of it was done through Medicaid. So most of it was done through the expansion of the Medicaid program. So expansion of coverage, big deal. It was really historic. We've never had as few uninsured people in America as we did after we passed the Affordable Care Act. The second thing that people should know that's really important, and this is where Trump really went to town during his administration, the Affordable Care Act for the first time created rules for insurance companies, right? So before the Affordable Care Act, insurance companies, you could be paying your coverage, and there might be even people on this call that have this experience, where you're faithfully paying your premiums every month, hoping to God you don't get sick. Then, you get sick, you get cancer, and your insurance policy caps out at $1 million. Or your insurer decides that he's not going to pay for something that your doctor ordered. And we've seen, many of these stories. So the Affordable Care Act really became a historic law because for the first time it outlawed that. right? So it outlawed discrimination against people with pre-existing conditions, whether your pre-existing condition was an addiction, or whether it was heart disease, or whether it was cancer, or whether it was a birth defect. It stopped insurance companies from capping or dropping coverage, which used to be perfectly legal. You know, your insurance company can say, oh, you need $2 million of treatment, but you only got 1 million. Well, we're going to cut you off now, right? That used to be perfectly legal. Gender discrimination, right? That was a big one for a lot of years. Insurance companies would charge women more, 30 to 50% more for a policy that a man who was her counterpart, same age, same race, could get for much cheaper. And then the policy didn't cover a bunch of things that she needed, which was another important thing that the Affordable Care Act did. It created standards for coverage. So you can't today sell insurance on the ACA marketplace if your insurance does not cover maternity care, if it doesn't cover addiction, if it doesn't cover prescription drugs, if it doesn't cover, right? So it created standards around health insurance that we just had never had before. So those were all big things. Now, in the Trump administration, a lot of what they did, and you all will probably recall, when Trump got elected in 2016, he said that his number one priority was to repeal the Affordable Care Act, right? He actually said that he wanted the bill to be the first bill that he signed when he got inaugurated into office. He was very ambitious about that. And it didn't happen, but it didn't happen because grassroots folks really stopped him from doing that, and stopped members of Congress from voting to pass the bill. Once he failed to pass the bill in Congress a few times, he realized that his only alternative was going to be basically executive action and regulatory change. And that's where you started to see this slew of different things that he did via administrative action that weakened laws. So, he had allowed insurers to sell short-term policies on the exchange, kind of what we call junk policies, right? Like, you have a policy, but unless you get hit by a truck, you really can't use it. He loosened up a lot of the rules around the regulatory functions. He made a lot of changes to Medicaid that would condition people's enrollment in Medicaid on how many hours they work, right? And you had to be able to prove that you could work those hours. He made a lot of changes in the non-discrimination features of the Affordable Care Act, right? A big thing that the Affordable Care Act did was it said, you know what, healthcare providers can't discriminate against you if you go in and you're a transgendered person and you're seeking treatment because you want to have a sex change operation. If you're a woman going in and you want birth control or you need an abortion, a healthcare provider can't discriminate against you. If you're looking for end-of-life care, a healthcare provider can't discriminate against you. So he reversed all of that and really enabled healthcare providers to discriminate. He reversed things like no-cost birth control. I mean, he was very busy. It was a very busy 4 years for him. So he did a lot of those things via executive action, and it did actually weaken the law. And where we saw the greatest weakening of the law was people losing coverage through Medicaid. And the number of Black and brown people that lost coverage was, of course, much higher than what we saw among white people. So he did some significant damage. But the positive piece is that the law remained intact, and most of the things that he did to the law are now being reversed by the Biden administration. So a stroke of the pen took apart some things, a stroke of the pen is putting them back.
What power a simple pen holds.
Mhm.
And as personal experience, I remember really starting to care about this issue, especially the junk policy, because I worked in retail throughout college, and before I became an organizer, or when I wouldn't be organizing, I'd go back to retail, and I had a junk policy until the Affordable Care, and those are junk. I went to the hospital, to the ER. I couldn't even use it then, really. I still had to pay out of pocket thousands of dollars before I could leave the hospital, because they basically said your insurance is useless, basically.
Yeah,
So
well, that was really common before the Affordable Care Act because, as I said, you could really sell anything as a policy. And so it was not regulated at all, right? And so even just the idea that you would regulate insurance like any other consumer product, I mean, for God's sake, we have lemon laws, right? To regulate whether or not you can sell somebody a crappy car, but we weren't regulating health insurance. The insurance industry is really powerful. They have a very powerful lobby. So they really resisted it for many years.
they really did. And thank you to folks putting in questions. Again, if you do have questions, putting them in the chat. After this little interview section, we'll go right into Q&A. So please, as you have questions, put them in. So you talked about now Biden's pen basically fixing what Trump's pen did. What is left to be fixed or to undo the damage done by the Trump administration to the ACA?
There's lots of executive things that that still have to be done, and there's also the matter of the lawsuit, right? Because the Trump administration orchestrated essentially a lawsuit to overturn the Affordable Care Act, and that lawsuit is still hanging out there, and we've got to figure out what's going on with it. The truth is that Biden, I think, will do fine, and his HHS secretary, they will reverse as much of the damage as they can do, and they will, to the extent that they can from an executive point of view, make improvements to the law, tweaks to the law. But the thing that I think folks should understand, particularly on this call, is that big changes that are still needed, right? And I see some questions about Medicare and Medicaid, why aren't more things covered? Those kinds of changes require legislative action, right? So anytime that you want to do something in healthcare and it's going to cost a lot of money or make a significant change in the industry, that has to be legislative, right? And that's sort of all the way up and down the line, whether you're talking about the Affordable Care Act subsidies that would make healthcare on the exchange more affordable because it's still too expensive for a lot of people, or whether you're talking about expansions in Medicaid. Right now, Medicaid for women that give birth, Medicaid provides 2 months of post-birth care, but it really should be like a year of post-birth care, right? Because the United States has the worst maternal mortality in the entire developed world, right? It's twice as high as it is in France or Sweden or England or any place like that. So those kinds of expansions, and definitely anything that we do on prescription drug prices, which is huge, huge, huge issue, all of that needs to be done through legislative action. And so really what people are excited about on healthcare isn't just that we have somebody to clean up the Trump mess, but that actually we do have the prospect of passing legislation, and passing that legislation could make a tremendous difference for people in terms of the affordability of their coverage, getting more services, even shoring up big programs like Medicare and Medicaid. There is a lot of opportunity there to really strengthen those programs, but it's going to require legislative action.
And before we go into my next question, for folks that may have no clue what the difference is, what is the difference between Medicare and Medicaid, and how do they work?
Oh yeah, that's a good one. That's a good one. So there's two big programs in the United States that are sort of the public insurance programs. Medicare is the program for seniors and people, to some extent, people with disabilities. So Medicare is what your grandma might have, people over 65 that qualify for the program. And it covers a lot of things. It covers hospital care, and it covers routine care and preventative care. But there's a few big omissions in Medicare that are really important, right? It does not cover vision. It does not cover hearing. It does not cover dental. So, what's ironic about that is all of those things are things that like you are going to need if you get older. So, seniors are having to pay out of pocket to get a tooth pulled. That's really hard for seniors because the average income for seniors is only about $27,000 a year. So seniors really cannot afford to spend that kind of dough on out-of-pocket care. The other big challenge in Medicare is prescription drug prices. And Medicare, unlike Medicaid, Medicare is the one program that does not negotiate prices with prescription drug companies for medicine. That's why we had for years the donut hole where people were paying 100% out of pocket for their drugs. Medicaid is also a public program, but Medicaid is for people of all ages. It started as a program primarily for low-income people, but over the last couple of decades, it's really expanded. And through things like CHIP, the Children's Health Insurance Program, which is part of Medicaid, it has really become a leading healthcare program for all kinds of people. So it's the leading insurer of children, kids under 18. It's the leading payer of birth, right? So it is the leading insurance for people giving birth. It's the leading payer of family planning. So it is the leading payer of people who are getting birth control services or prenatal care, any of that stuff. Um, it it is the program that pays for long-term care, which is nursing homes or in-home care. If you're going to have somebody come to your house, Medicare doesn't pay that, right? If you have a heart attack and you're a senior in Medicare, your Medicare will pay for the hospital care, and it will pay for a visiting nurse for a few weeks. But if you find that you have to go into a long-term care facility, that's Medicaid that's going to pay for that. So there are two different programs. The other big difference to know is Medicare is funded through a dedicated tax that people pay in the payroll. Medicaid is funded through a combination of state and federal funding. And in most states, it's sort of like a 70-30. Like the state will pay 70%, the feds will pay 30%. In some states, the match is much higher. So it's both state and federal. Medicaid, in most state budgets, Medicaid is the biggest item in the state budget.
Yeah, and unfortunately, we've seen some cuts here in Nevada this last special session to Medicaid, which is terrible. Um, so hopefully we can fix that this session. So other than all of the fixes you've kind of talked about that we need to work on for the Affordable Care Act, Medicaid, Medicare, and before we go into prescription drugs, because I feel like that's a whole topic on its own, what are some what is the future for the healthcare issue in like the next couple years? What is sort of left to be done other than those fixes?
Well, I mean, look, I think it's one thing to make healthcare more affordable, and that's really important. But at HCAN, the thing that we fought for in the healthcare law was really the public option, right? So it was the idea that if you like your private insurance and you want to roll with that, fine, right? Like it should be affordable for you. They shouldn't be able to jack up your prices, and you should actually get the healthcare that you need, as opposed to some BS policy that you can't really use. But for people that don't want to get their health care through a health insurers, they should be able to have access to a public option, which could be a Medicaid buy-in or a Medicare buy-in. And we've seen some proposals in the Biden administration, right, to allow people to buy into Medicare at 50, not waiting until there's 60, 65, and giving everybody the choice of having Medicaid if they don't want private insurance. There's a lot of benefit to that because Medicaid has much lower overhead costs than private insurance. And the reason for that is because there's no profit. There's no CEOs to pay. You don't like, it's not a million people taking a cut off the top. So I think the future of healthcare really, in my mind, the direction we should go in is a couple of things. And some of these are really just directly tied to the pandemic. I think the public option is more important than ever. And especially in the pandemic when we've seen people lose their jobs and then what happens? They lose their health care. We have to do something about connecting people's jobs and healthcare because that is not a tenable way to make sure people have healthcare in the new millennium. There's just too many people in jobs that don't have healthcare, right? And like the gig workforce, right? If they're a server and they drive for Lyft, but they don't have healthcare, they're one of those jobs. So I think there's a reimagining of healthcare that really needs to happen. And that's what I think we really need to see. The other thing, the other couple things that I would say is we need to have a serious discussion about public health and the fact that almost every debate that we have in Washington, D.C. about healthcare these days is about financing. It's really not about health. And the reality is health outcomes in this country are not as good as in other countries. We spend way more money and we have a lot of other things that contribute beyond the healthcare system to health outcomes. We need to think about health a lot more broadly and holistically, right? In countries, for instance, where people have paid family medical leave, their health outcomes are better. Their healthcare is not necessarily better, but their health outcomes are better. Of course, that would make sense. So public health, I think really huge issue, really important. And then I think I saw a couple of people put Medicare in the chat. The aging of the population is a serious issue that nobody talks about. If you ask me, it's the number one public health issue that we have, the number one financing issue that we have, the number one revenue that we have, right? For many years, the immigrant population that has come to the United States has really prevented us from seeing a crash because we have an aging, in the United States, the population of people over 65 is going to double by 2050. It's going to double, right? So if people think we have problems now getting enough care for all of our folks, guess what? You ain't seen nothing yet, because in countries like France or countries like Japan, where they've been selling old people diapers at much higher rates than baby diapers for many, many, many years, there is a serious crisis because the aged population is much more expensive to provide healthcare for than young people. And so we're going to start to feel a crunch. You probably haven't heard people talk about it, but just, FYI, it's a coming.
Yeah, and we have to fix it. I mean, we should honor the folks that came before us by helping them age
Mhm.
gracefully.
And
And
remember that we're all on our way there, right? Everybody has a vested interest in, understanding that, we have technology that is keeping people living longer and keeping them healthier. And that is a good thing, but we should stop pretending like we don't know what's happening. We should plan for it.
exactly right. So, where, before we go into one of the issues that has like its own Pandora's box, which is uh, uh, prescriptions, overall, what is your sense of the first few weeks of the Biden administration when it comes to healthcare, and where do you think they're going next? What should they be working on? What are your thoughts?
Well, look, we have really a pretty remarkable situation, um, because the pandemic is remarkable. It shapes the whole context that we're in, and it is like the things that we are seeing happen in terms of fiscal policy, budgetary policy, all of that kind of stuff is pretty unprecedented. Remember that when Obama took over in 2008, there was a huge recession, right? It was a great recession, and Obama passed the American Recovery Act, which was less than $1 trillion. It was about $838 billion to try to address that. It was not nearly enough, and it contributed to a pretty sluggish recovery. But the level of political resistance that he got was one of the reasons why the package was a small package. Now, here we are, fast forward. We've had Congress in gridlock for 2 years, and last year, Republicans and Democrats passed $4 trillion in COVID relief. It's a pretty astounding amount. Joe Biden comes into office. First thing he does, he's not even inaugurated, is he says we need 1.9 trillion more at least, just for relief. And he says, by the way, that's just for relief. Like in a minute, I'm going to come back and I want to do economic stimulus to create jobs and to get the economy rolling again. And that's going to be a few more trillion. Now, that is incredibly bold, right? Because there is a lot of nervousness about spending. So for a Democratic president to show up in Washington and say, this is a rich country, we need to get things back on track. We're not going to nickel and dime the American people. We need to spend this money. Why not? We spent $2 trillion giving tax breaks to billionaires during the Trump administration. We can definitely do this. So it's actually a pretty exciting time in Washington to see the relief package moving through reconciliation that has big improvements that we've never really seen before. We've never seen anybody saying that they're going to scrap the Medicaid rebate cap to pay for a full year of maternal care for people who give birth. We've never seen a proposal to expand subsidies in the Affordable Care Act for everybody, whether it is upper income people, middle income people, lower income people. I mean, there is a lot of legislation moving on healthcare and many other related issues in this package. It's pretty exciting. And come middle of March, when hopefully this package is passed, we will see, this relief package that we're watching, the American Rescue Act, that's moving through Congress this week. I'm going to go to the floor probably next week. It's an appetizer, right? The main course is going to be the stimulus package. And the hope is that we're going to see a lot on healthcare in the stimulus package, particularly for big rural states that have been underinvested in, where healthcare really is an important economic driver. But that we're also going to see green jobs. We're also going to see, the building of infrastructure, right? Like the full on package that really would sort of insert a lot of money into the economy and get things moving, rebuild small business, invest in public education and healthcare. So I think it's a very exciting year. As you guys know, right, this is a new administration. Our best chance to pass policy is in the first year. We probably can pass a little bit more next year. Then we have the midterm elections. Once we have the midterm elections, it's entirely possible. Historically, the trends all tell us that Democrats will lose one chamber. If that happens, then we're back in gridlock. Gridlock is not super fun up here, right? It basically means that you can't, there's very little that you can pass into law. And so we spend a lot of time just fighting with the opposition party and not legislating for the people of the country that actually need stuff. So there is a lot of opportunity, certainly on the legislative front. And I'm not even going to tell you about all the great things that the agency heads can do in their agencies, right? The department, I mean, what's it going to be like when the Department of Health and Human Services is not run by a pharma exec? I'm going to bet it's going to be a heck of a lot better. That's what I think, right? Like, what's it going to be like when we actually have agencies that are populated by public servants and not just, corporate donors of the current administration? So I think there's we have a lot of opportunity, and it's going to be really needed because states are struggling. If we don't get COVID relief at large scale, moving from the federal government to states, we are going to see really an economic recession in states like Nevada, like people have not seen for 30, 40, 50 years. So it's a pretty urgent matter.
Absolutely. And speaking of agencies, and she sort of ties into our next topic for my last two questions, Senator Ivana Cancela, who is a big proponent of lowering drug costs, prescription drug costs, is now going to be at HHS. So it's going to be amazing to have people like her who are real public servants and actually know what the real issues are working on that. So it's exciting. So speaking of the fun issue of prescriptions, give us the 101 if someone has no idea what the issue and why we need to lower prescription drug costs. Tell us, where we are now, what the landscape is.
Sure. So it's going to come as a shocker, but the price of prescription drugs in the United States of America is way the hell too high, and people cannot afford their medicine. Even really basic medicines. Like, I'm not even talking about the fancy stuff like cures for cancer. I'm talking about, albuterol, asthma inhalers, insulin, arthritis medicines. Those medicines are so expensive that they're really out of reach for a lot of people. We saw the price of insulin go up 400% in just a couple of years. So, one thing that I always ask people is, why is the prescription medicine so expensive? Like, what's driving? I mean, insulin is 100-year-old medicine. There's nothing new about that. They're not changing the formula or anything, right? So why is it so much more expensive now than it was 5 years ago, 10 years ago? The main reason is a pretty simple reason. It's the one that you're probably imagining. The reason that drug prices are so high in the United States of America is because we're one of the very few countries that just allows the companies to set their own prices. We don't regulate the prices. They don't negotiate the prices. In the US, the prescription drug companies get public money to develop drugs. Almost every drug is developed with public money. In fact, every single drug that got FDA approval between 2010 and 2020 was developed with public money. So there's vast sums of money through the National Institutes of Health that go to develop medicines. We're seeing it with the vaccines, right? The vaccines were all developed with public money. So you would think, okay, well, these things are developed with our money, so like they should be reasonably priced. That seems fair. It does seem fair, but that's not how it works. The way it works is these companies get all this free public research. They take the research, they develop a medicine, they patent the medicine, they get an exclusive license on it. That usually gives them 20 years of exclusivity. What that means is that they have a monopoly on that drug for 20 years. So they're the only people that can manufacture and sell it, and they have no competitors. Often they can stretch that monopoly beyond 20 years because they can play all kinds of games with the patents. They build patent thickets, they make a little tweak in the injector thing for the insulin, and boom, they've got a longer exclusivity. So really a lot of the reason why we have such high prices in the United States is because they don't negotiate. The drug companies don't negotiate with the government the way other countries do. They're not regulated. They have exclusive patents on medicine, and it's very hard to drive down costs without generics. Experts say that you have to get 6 generics on the market to drive down the cost of a brand name drug. And it will take many years to do that because they have that guaranteed exclusivity for a period of 20 years. So, drugs like Oxycontin, right? Oxycontin's got a patent that's a 30-year patent. They extended the patent of Oxycontin to ensure that they wouldn't have any competition and they could make even more money. So the result of that is that prescription drug companies are the most profitable companies in America. Not the most profitable companies in healthcare, the most profitable companies, period. More than oil, more than communications, more than any of them. And drug prices are the fastest growing prices in healthcare. So the medical, it's the price of prescription drugs is rising faster than any other medical good or service. And the companies are obviously tremendously profitable, and they continue to drive profits, and they're heavily subsidized by taxpayer money. So even little things like if you're up late at night watching TV and you have to watch all those crappy commercials with the 18,000 side effects, like take this medicine and your nausea will go away. Oh, but then these 85,000 things could happen to you. You're actually paying for those commercials, right? They get a tax break for marketing for those commercials. So, their CEO pay, they can write that off. The opioid, I don't know if people saw this in the news, but we just had a big settlement on the opioid companies, big ones like Johnson and Johnson, that were really responsible for manufacturing the raw components and really spurring the opioid crisis. They just settled with the Department of Justice, huge settlements. Now they're trying to get a tax break on their settlements. I mean, it's just like, it's full on cray, like it is full on cray how much money and how much advantage they have. So, look, we're not going to solve the prescription drug crisis in America until lawmakers are willing to take on pharma. That's all there is to it. Like pharma, if pharma companies are allowed to set prices, to raise prices twice a year, to control patents, we are never going to bring down prices. And even if we can manage to get costs under control for some people, that cost will just get shifted around, right? Because if I say, okay, 50 people in Nevada, we're going to cap your costs on insulin. That's great for you 50 people. The problem is that the prescription drug company is going to keep jacking up the price of insulin. And at some point, the state's going to have to figure out how to pay the difference. And mostly they're going to pay the difference by coming to the rest of y'all and saying, we're going to raise your premiums, or we're going to need to tax you a little bit more to pay for this cost cap for this other group of people. So things on cost can be helpful, but the real thing is about tackling price. We've got to take them on and tackle price.
My favorite disclaimer whenever those ads come up for those prescription drugs is sudden death may occur. And I just get freaked out, like, sudden death, okay.
Yeah. Get through a company, makes you want to run to the pharmacy and grab that thing off the shelf, huh?
I'm just like, wow. And you got a tax break for this ad where you freaked me out. So, like you said, the most important part of this is lawmakers taking on pharma. And that is not an easy task, but it can be done. We've seen it here at the local level with Senator Cancela, as Steve Sebelius, a reporter, called her, #1 job creator in Nevada, because she she started to take on pharma, and all of a sudden there was like hundreds of lobbyists showing up in Nevada thanks to pharma. So what can elected officials at any level, but really the federal level, what action steps can they take to take them on in like this session or the next or whenever they want?
I think we're going to see a lot of action on prescription medicines. In fact, in the relief bill, pharma's already going crazy over the relief bill because there's a provision that proposes raising the rebate cap in Medicaid. And it's an arcane policy, but basically Medicaid negotiates prices with drug companies, and then drug companies will raise the price, right? So let's negotiate $10 a pill, but the prescription drug company is going to raise that price faster than inflation over the coming year. Well, when the drug companies do that, they have to pay a rebate back to Medicaid, which is good. They should, because they just jacked up the price of that drug. But they only used to have to pay, or if this law doesn't, currently the law is they have to pay 100% of the price. So if they jacked up the price, if the price was $10, they jacked it up, another 10, 100%, then they would pay the full 100%. They'd have to pay that money back to Medicaid. Sometimes they jack it up 3, 4, 5 times the cost, right? So that the pill isn't $10, it's $50 or it's $60. But the cap made it so that they only had to pay back the $10. right? Like if it was $50 more expensive, they didn't have to pay the rest. So this would lift the cap and they'd have to pay the full amount of their price inflation, which is a really good thing. It would raise about $14 billion over 10 years. So it's not chump change money. It's pretty good money. But we're going to see the big drug bill. We're going to see a lot of drug legislation pop up in these packages. Of all the things that we can do on healthcare, there's only one thing really that saves money, and that's lowering the cost of prescription drugs, right? So you're going to see it in the packages as a paid for. Later this year, we're probably going to see HR3, the Lower Drug Costs Act, which is a bill that would finally correct the problem in Medicare and allow Medicare to negotiate for the price of prescription drugs in Part D, which would be a really big deal. Now we're trying to expand that bill so that then those negotiated prices also apply to people who don't have insurance and also apply to people who have private insurance. And we're trying to expand the set of drugs. So people are definitely going to see a lot on prescription drugs. And the big bill to look out for is really HR3, the Lower Drug Costs Act.
Yeah, we're very excited and to see that bill, and very excited that 99% of our delegation has really fought hard for HR3. We are excited. So I want to go now to audience questions. Thank you to everybody that has used the chat function. So I'm going to go through, scroll up and find our first question. Lots of folks saying hi. And from Iris, I think this was our first question. Why does healthcare reform not include senior issues? It is if we do not exist. Having Medicare and Social Security is not the beginning and end of living a full life. Seniors are frequently mistreated in a doctor's office without respect and courtesy.
Well, look, I could have spent the whole hour talking about this question, but I totally agree with you, Iris. Look, I mean, Medicare is a popular program, but it's not a perfect program. It doesn't cover, it's expensive. Most people who have Medicare have to have also an Advantage plan to pay for stuff that Medicare doesn't pay for, right? And then it doesn't cover health, like vision, hearing, any of that stuff. So, I will say the current administration, HR3, the bill that we were talking about, was really an interesting bill last year because it would have lowered the cost of prescription drugs to raise about $365 billion. The $365 billion would have gotten reinvested into providing the missing services in Medicare, which would be a big improvement in Medicare if people could get dental and vision and hearing. Because right now, seniors are like taking up collections in their churches to pay for their hearing aids, which is really ridiculous. So I think it's actually part of a bigger phenomenon where, for some reason, seniors just don't have as much clout with lawmakers as they used to have. It's totally bonehead, to be honest. Seniors are the most powerful political constituency in America, and when they vote, it terrifies the crap out of legislators. So I would encourage seniors to really organize, because if they really want something, they can win it just about faster than any other constituency. They vote at much higher rates. We have a midterm election coming up in 2022. Guess who votes in those? It's not college kids, it's seniors.
Absolutely right. And as someone that just went through the Medicare application system with my mom to get an Advantage plan, number one, that's a whole world to try to navigate on your own.
I'm surprised you didn't have to take vacation time to do that. Jeez.
I should have, because it is so, and we're still almost done. We just got to get Part D. And this kind of ties into Mary's question, Mary Dungan, who I want to go to next. But when I saw that, one, that there's a premium, and two, that it's a monthly premium and how much it is, I was like, wait a second. If it wasn't for my mom's pension, she would probably have to go get a job, a part-time job.
That's why a lot of people on Medicare are also on Medicaid. They're getting Medicaid to help them pay for Medicare. They're called dual eligibles. It's a growing number of people.
Yeah. And we seriously looked into that because, wow. And this is Mary's question. I turned 65 in November and I got a bill for around $500. I thought Medicare, which is what I thought my mom thought, was something you paid into your whole life. Is there a payment due to the government when you become eligible?
Oh, you got a bill from Medicare?
That's what it sounds like.
Oh, interesting. I bet there's a threshold. I don't actually know the answer to that question, but I bet that there's a threshold where you have to hit a certain threshold of payments before the coverage will kick in. And I bet that's what it was. But I mean, I think, again, you're signaling a thing about an issue with Medicare, which is that people do pay into it their whole lives. And when you're on Medicare, the thing that you notice is, okay, you have guaranteed health care, like they can't deny you coverage, but it is costing you a boatload of dough that you didn't think you were going to have to pay out of pocket, whether it's for co-pays, or whether it's for this kind of threshold thing, or whether it's premiums and advantage plans, or whether it's out of pocket prescription drug costs, or it doesn't cover your eyeglasses. So I'm a huge fan of Medicare. I think it's a great idea, but we actually just do need to make it like more reasonable, more affordable. We need to put more into it, right? Like we can't, it is ridiculous that people work their entire lives and then can't go to the dentist when they need a tooth pulled.
Yep, that's exactly right. And if I could get on my soapbox, the application process could totally be modernized. Just to say, between that and unemployment in Nevada, we've got a lot of modernizing to do in America.
Yeah. Well, there's been very active resistance to, we didn't have electronic medical records until the Affordable Care Act. So that means we've only had electronic medical records for like 10 years. And, this patchwork system, it's a really challenging system.
Yeah, it's absolutely insane. So thank you, Mary, for your question. Next up is I think it's more of a comment, but maybe a little bit of a question. Marilyn Horween said, I have not had ACA, but from people that I know had it, said that they had large copays and that they did not have good coverage. And sometimes, I've heard about that too, especially when, the Affordable Care Act fight was in Congress, or the, repealing the Affordable Care Act fight was in Congress. What is the case with that? What happened with the ACA that a lot of people saw high premiums, high copays, and what they felt like not good coverage?
I think that people are still seeing pretty high copays. So I think a couple of things happened. One thing is all of the stuff that Trump did over the last 4 years created instability in the market, and a lot of insurers just pulled out of the Affordable Care Act. That's a problem, right? In general, one thing to note is the consolidation of insurance companies. So they're merging and getting bigger and bigger and bigger, like the consolidation of hospitals. It creates fewer options for people. When you only have, one insurer in the marketplace, like all you can get is Aetna, it gives Aetna a lot of power to just jack up premiums because they're the only provider. So I would think, I think that's actually a growing problem that's not particular to the Affordable Care Act. We're seeing that type of like monopoly and consolidation across many, many industries, and it's really worrisome. But I also just think it's expensive, right? For a lot of people that are paying 10%, you can pay up to 10% of your income for healthcare. That is a lot of your income if you're a low wage person. And because we had an administration that wasn't willing to put more money into subsidies, people were paying a lot of it out of pocket. And I will say, if the COVID Relief Act passes, that's going to help a lot of people, because no matter where you are on the income scale, you're going to get help for, like, if you're under 200% of poverty, your insurance basically is going to be free on the ACA. So I think it's right that it is very expensive, and it's gotten the more unstable the law has gotten and the more attacks on it, the more expensive it's gotten, because insurers are pulling out. They're thinking about their business, right? And like they're going to go elsewhere because they don't want to take the risk. I don't know. I haven't heard as much about the quality of coverage issues, to be honest. I believe it. I just don't know what would account for that, except that in the past 4 years, there have been a lot more policies sold that are what we call the junk policies, that just don't cover all of the essential health benefits. So like those are the policies where, like, if you have a car crash, you can go to the doc, but if you have a sore throat that might turn into pneumonia, you can't go because it won't really cover that.
Yeah, those are real junk policies. Rita asks, what move is there in the country and locally to cover under healthcare insurance, holistic medicine systems such as homeopathic, naturopathy, Chinese medicine, Ayurvedic medicine, etc. NIH has worked on integrative healthcare ever since the late 90s, yet officially it seems that the country does not cover these efficient systems of medicine. Can you speak to that?
Yeah, I don't know anything about it, except that I myself did try I just had COVID in November, and I did go to a Chinese herbalist because I had a colleague that was like, "You have to do this. It's going to speed up the recovery." But did pay for it out of pocket. My insurance did not cover it. I don't actually know, and I actually don't know anything about the politics either of how you get stuff like that covered. This is what I'm going to say. I think in America, we love doctors. We love Western doctors. Western doctors have a lot of political power. And I could see them trying to shut down the inclusion of those kinds of medicines. Like for many years, they shut down, midwifery and doulas in obstetrician care. So I don't actually know that much, but it is an interesting topic, I bet. You've inspired me to look something up after this call.
Absolutely. And you mentioned doulas in midwives, which will be a topic in our next progressive university about reproductive justice. So folks are like, what is a doula? What's a midwife?
Yeah.
Tune in on the 17th. We're going to talk about that, especially because there's legislation around getting them to be included at least in Medicaid.
Mhm.
And
That is going to be a fascinating topic because there has historically been a huge effort basically to just crush the field of midwives. It's actually like totally crazy. Anyway, I have lots of resources on that if you're interested.
oh, absolutely. I'm loving the whole subject
Yeah,
as,
it's really fascinating.
yeah, yeah. So one thing is, hang on one second, uh, going through some comments. Erica, how do you respond to people who shout socialized? I imagine, uh, and all the efforts to actually increase access to healthcare. How do you respond to those people that, were trying to get socialized medicine?
Yeah, I don't even really know what socialized medicine means. I mean, look, the most popular healthcare programs in America today are the ones that we have the most control over because we pay for them and we try to keep the insurers out. It's Medicaid and Medicare. So, I think it's like we don't have anything close to socialized. We don't even have public health in this country, right? We have nothing close. There is no part of the healthcare system in this country that does not drive profit and doesn't make profit. So, I guess if somebody were to yell socialized, I might yell back, I wish, I wish we could. But, look, I think it's a ploy, right? I think it's people who are, sort of playing a card that to frighten people, but there's no real substance in it. And at the end of the day, here's what we know about healthcare in America. It's really hard to change the system. We don't have the public option. It isn't because we didn't fight for it. It's because people are just scared. People are scared. They hate their insurance company, but guess what? They'd rather have the devil they know than some other unknown thing. And that sort of makes sense. People worry about healthcare. So I think until we get to a place where we actually can reduce costs, but we're going to have a reckoning on healthcare in this country, right? Like doctors in this country make more money than any place else in the world. You know what? If we want to have more affordable healthcare and Medicare, we can't let doctors own like 3 mansions in Maine. We might have to pay them slightly less. Yeah, how's that for socialism? Ooh, scary.
um, and so Iris made a good point, and this kind of goes into, what I was talking about that Medicare plans, not only do you have the premium, but now their out-of-pocket costs are increasing for folks that are under Medicare. Can you talk a little bit about that and how that can be fixed?
Well, keep in mind that the Advantage plans are private plans, right? So it's just a private insurance plan that's attached to Medicare. So we pretty routinely see the out-of-pocket costs and premiums go up in those plans. I also think you're not going to hear a lot about this on the news, but it is kind of a scary thing happening behind the scenes that we really need to take action on the Medicare trust fund, right? The shrinking revenues because of COVID. So what happened, people didn't work, they didn't pay into the system, which means there's shrinking revenue in the trust fund. We're going to have to do something to shore up the trust fund, or the trust fund is going to start to actually feel the strain of that, and people are going to see their prices go up. So the fastest growing part of Medicare right now is the Advantage plans. It's the privatized part of Medicare. The bigger the Advantage plans get within Medicare, the more Medicare is going to start to feel like regular insurance, and the more it's going to start to mirror the cost of regular insurance.
Yeah, it certainly felt that way signing up for it and getting stuff from United Healthcare and
Yeah.
all that. So, and this goes back to this is a question from Gisela. Um, goes back to the public option. Are the large hospital systems, which is another big corporate part of this whole thing, supportive of a public option?
The large hospitals, no. Well, no. They're more supportive of a public option than they are of like Medicare for all, but generally, no.
Short and sweet. Nope.
I mean, look, the for-profit sector, which hospitals are a huge part, they don't want to see less profit in the system. They want to see more profit in the system, right? Because the more profit there is in the system, the more they're going to get a cut. So, anytime you see a proposal that is going to reduce administrative costs, that's going to reduce overhead costs, physician pay, reimbursement rates, hospitals are generally not going to be in favor of that kind of proposal. I know it's super Debbie Downer. I'm sorry.
uh, so one thing, it was also a comment, I believe, from Maryland, but it's also sort of an interesting topic, and I wonder what your thought is. Training doctors and we don't really have, even, within sort of the care system, a medical infrastructure, especially in certain communities. Uh,
Definitely. Huge
what
issue. Huge issue. I mean, one thing that's in this package, in this relief package that's moving, is the creation of 100,000 public health jobs, right? Because the public health infrastructure has been completely hollowed out. And in a lot of places, it used to be years ago that in a public health department, you could get your flu shot, you could get an STD test, you could get like some basic health care. Most public health departments don't even provide that anymore. Now the public health departments, like, they inspect restaurants and give out citations if they find vermin, right? It's that type of thing. So I think that that's absolutely true. And I think the issue of doctors is a huge issue, right? We're not attracting people and incentivizing people. And actually for one of your university sessions, you should really invite AMSA, the Medical Students Association. The medical students in this country are having to pass laws to restrict a physician work week to 80 hours. That's the physician work week, 80 hours. Now, really, would you want somebody operating on your parent or your spouse in the 75th hour? Because the culture of medicine is really perpetuating that. There are remedies, like we've seen this in other countries, right? If you want more doctors, more family physicians, more doctors serving underserved areas, then incentivize it. Like, recruit them, pay for their college education, and give them a year's pay for going out there and serving in those communities, right? Again, this is like part of the function of, creating a market rather than a healthcare system. In a market, it's whatever the market can bear. If we wanted to have a public health infrastructure, we wanted physicians, we wanted to serve underserved areas, we would have a public health workforce, and we would recruit doctors, we would pay for their education, we would send them out, we would compensate them for doing their 2 or 3 years in a rural area before they move on to something else. And that would be really valuable. So there are definitely models and solutions for that, for sure.
Wow. Yeah, I've been operated on, and I would not have wanted that doctor to be on their 75th hour.
It's really, we never talk about this in healthcare, but one of the most dangerous things in hospitals, medication errors, and sepsis, right? And sepsis will kill people very quickly, both entirely preventable, a lot of med errors and sepsis, not recognizing sepsis in emergency rooms, is because of the staff is fatigued, right? And you can imagine right now during COVID when people are just working around the clock.
Yeah, absolutely. So, and this is going to be our, I believe it is, there's lots of comments because you spurred great discussion in the chat. And I believe the last question, this will be our last question before we wrap up. But if folks do have more questions, feel free to email them to me at mariateresa@battlebornprogress.org. I will put that in the chat so folks can note that down. I know a lot of you want to get involved in this, especially Rita, on the issue of Eastern medicine and sort of non-Western medicine being. So whenever we get to that, MJ, we have someone willing to help. So our last question comes from Susan. The ADA rule preventing pre-existing, the ACA rule preventing pre-existing conditions do not apply to Medicare. A supplement plan can deny your application if you try to change plans. Why didn't Congress include this protection for Medicare in the ACA?
Well, the main reason is because under Medicare, people automatically get coverage once you hit 65, right? So Medicare was not a program like private insurance, right? In private insurance, the insurance companies could deny somebody coverage based on any set of criteria, right? You're too old, you've got high blood pressure. We didn't have that issue in Medicare because Medicare has just an automatic trigger. You hit 65, you're eligible for Medicare, you go into the program. So that's why Medicare was not, was not included. Now, I don't know what the supplement plan can deny your application if you try to change plans. I don't think that's probably for pre-existing conditions. I think that's probably, I assume a supplement plan is probably an Advantage plan. I assume that that is actually not tied to pre-existing conditions and more tied to the timing of when you sign up, right? So there's very strict enrollment periods. This is like part of the problem for older people that don't have somebody to help them navigate the system, is like if you don't sign up between this date and that date, then you miss the window, you have to wait, they deny you, you got to move on to a different one. So I don't think I don't think that that's actually tied to denying somebody coverage because they have a pre-X. Because pretty much everybody in this age group, by the way, is going to have a pre-X. I mean, I hate to break it to people on the phone. If you're over 45, you probably have a pre-X. It was a shocker to me too, but there it is.
There it is. And with that, that is our session. For folks that are in our chat, I have put my email and phone number. If you do have any other questions or want to get involved, feel free to contact me there. And thank you for tuning in and chatting and being engaged in this very important topic, especially in the world of COVID. And MJ, thank you so much for joining us. Any parting words before we click leave on the Zoom?
No, thanks to everybody. It's so great that people are engaged in having these discussions. Anytime we've seen anything good happen on healthcare or basically any other policy in America, it has really been just when regular people got engaged and pushed the change with their legislators. So, everybody who works in DC who really understands how change works, it doesn't happen in DC, right? No change is possible in DC without people in the states forcing it up from the states to the Hill. So really exciting to be with you all. Really enjoyed it. Thank you.
Absolutely. Thank you. And thank you, everyone. So we are going to give you the rest of your Monday, and hopefully we will see you on Wednesday, the 17th, this Wednesday, to talk about reproductive justice. So we'll get to talk about the midwives and the doulas, among all other things with reproductive justice. And we're lucky to have Dr. Tony Bond, who's one of the founders of the reproductive justice movement. And so we are going to have her on to teach us and lead the way on what that issue is. And so we are happy to have you at this session, and we hope to see you this Wednesday. Thank you, everyone.
Bye all.
Bye.